All right, so last time left off talking about motions of the hip. So remember, in terms of actions that occur at the acetabulofemoral joint or AF joint, which is the anatomical name that we're going to use for the hip, the actions that you get include flexion, which is bringing the leg straight forward, extension, which is straight backwards, abduction, taking your leg out to the side, abduction, bringing it back towards midline, and then internal external rotation. So internal rotation, taking the front of the femur, rotating toward the midline, external rotation, front of the femur, away from the midline. So remember that the motions are basically the same as you saw in the shoulder. We're just moving them down to the hip. So they look exactly the same, they're just at a different joint. So we left off talking about, or before we got to, the capsular ligaments of the hip. So there are three primary capsular ligaments that stabilize the acetabulofemoral joint. And each one of them runs from one of the components or one of the parts of the innominate bone. So what are the three parts to each innominate bone? What are the three sections to each innominate bone that we talked about last time? Anybody remember? Yeah, there we go. So ilium, ischium, pubis. So remember, in terms of terminology, if we think about the pelvis as a whole, it has two innominate bones, a right and a left, and then the sacrum in the middle. So each innominate bone then is further subdivided into the ilium, the ischium, and the pubis. Ilium on top, or more superior, ischium, posterior, inferior, and then pubis is anterior. So each of these capsular ligaments is going to run from one of those parts of the innominate bone to the femur. So the first one is the iliofemoral ligament. So it runs from the ilium to the femur. And it essentially originates along that anterior aspect of the acetabulum, close to the AIIS, and it's going to insert, and you don't need to know origin insertion for ligaments, I'm just killing time here, but it's going to insert along the intertrochanteric line of the femur. So the intertrochanteric line is the space between the greater trochanter here and the lesser trochanter here, but along the anterior aspect of the femur, as opposed to the intertrochanteric crest is on the posterior aspect. So where it says taught in, that means what motions of the acetabulofemoral joint this ligament limits. So the iliofemoral ligament is going to limit hip extension. So if you fully hyperextend the hip, the ultimate, or one of the ultimate limiters of that motion is going to be the iliofemoral ligament. And then it also limits external rotation. So again, taking the front of the femur and rotating it away from the midline. So if we've got an iliofemoral, then we obviously have an ischiofemoral. So that one is on the more posterior aspect. So now the ischiofemoral ligament is highlighted there for you in green. So that one's going to run from that posterior margin of the acetabulum. The fibers are going to sort of spiral along the neck laterally and superiorly, and they're going to insert sort of on the medial aspect of the greater trochanter. And so in terms of what actions are limited by the ischiofemoral ligament, you can see that they are internal rotation, so taking the front of the femur, rotating it toward the midline, as well as extension and abduction. So bringing the leg close to the midline. So that's the ischiofemoral ligament, again, on the posterior aspect of the joint. And then the last one, of course, because the only one we haven't talked about yet is the pubis. So the pubofemoral ligament is the one that's highlighted now in green. The pubofemoral ligament runs from that anterior and inferior aspect of the acetabulum, or the acetabular margin, also from an area called the iliopectineal protuberance, or iliopectineal eminence, that's the word I was looking for, which is this little bump that's right here on the ilium. And that'll become important here in a few slides. Anyway, so it's going to insert there kind of along the neck of the femur as well. So you can see in terms of actions that the pubofemoral ligament limits, it limits abduction, also limits extension, and then external rotation. Okay, so between those three capsular ligaments, what actions have we not limited very well? Or at all? Okay, we haven't limited flexion at all. Okay, what else? So let's leave those to the shoulder, but good guess. So we haven't limited flexion at all. Have we limited adduction? Yes, but only one of the three limits adduction. So there's So adduction we haven't really limited, and then internal rotation. So only one of the ligaments limits adduction, which is the ischiofemoral ligament, and only one of them limits internal rotation, which is also the ischiofemoral ligament, right? So having limited flexion at all, only one of the three limits adduction, only one of the three limits internal rotation. Not coincidentally, if you're going to dislocate your hip, the common mechanism of injury, the most common mechanism of injury for a traumatic hip dislocation is a combination of flexion, adduction, and internal rotation. So essentially what ends up happening is that they're kind of in this position, so where their hip's in flexion, but usually they're on the ground, so their weight bearing on that leg. They're in flexion, adduction, internal rotation, somebody kind of pulls them down. So I'm going to show you a video of that. I'm going to have to unplug my mic for a second for those of you watching the video, because I want sound on this. Hopefully the sound will work. All right, so I'm going to show you a video. So these are two pretty gruesome videos. The first one is a mechanism of injury. I'm showing you an actual hip dislocation in a football game. And then the second one is fixing that. It's a reduction of a hip dislocation. And that's the more gruesome of the two. So you don't have to watch either of them, but I think it's illustrative. It's kind of interesting to see it happen. And hopefully the sound works. Watch the quarterback in black. Oh, how's that working? That's okay.
Trainer got up there quick.
She did, yep. Yeah, the athletic trainer gets up there pretty quick. And so, you can't hear the commentators, but they're like, oh no, that looks like a knee injury. So, now it's not going to work. Alright, so, turn the sound down. It's like Wayne State and Nebraska Kearney or something. Anyway, so one more time real quick, since I wasn't really watching. Actually, they did a slow-mo. Never mind. Let's go over here. Come on. There you go. All right, so quarterback running with the ball. You're going to see he kind of gets dragged down. That leg is stuck in the ground there. And then you'll see how it pops up right there. Right? Like that's stuck in that position. So what happened is that so in terms of the actual anatomy of it, wait till the next video. The actual anatomy of it is that as the hip moves into flexion, adduction, internal rotation, you've only got just a little bit of the femoral head actually in contact with the acetabulum, and then that really strong axial load is actually going to push the femur behind the acetabulum. So it pops back there and it gets stuck. So almost all hip dislocations are posterior dislocations, meaning that the head of the femur is going to pop behind the acetabulum and get stuck back there. So in terms of what it looks like that. So that leg typically gets stuck in flexion, adduction, internal rotation. So that's the position that he's in there. And then if their leg is not quite as dramatically flexed as his is, you'll notice that the dislocated leg is shorter. So there, I've got another picture that's actually not in the slideshow, but it's from a bicycle accident. And the lady with her dislocated hip, the leg is probably an inch shorter than the other side. So that's one of the other things you'd look for. Well, what do we do about that? So we have to transport it to the hospital. Usually the way they splint it is basically you take a pillow and put it between their legs, and then you use an ace bandage and kind of wrap them together, put them on a gurney, and then send them to the hospital. At the hospital, what are they going to do?
They pop it back in place.
Yeah. How do you think they do that?
No idea.
Let's find out. Yeah, so the next slide is a reduction of a hip dislocation. So if you reduce something, it means you put it back, right? So if you reduce a shoulder dislocation, put the shoulder back in place. And so that's what we're doing here. And I'll tell you in a minute why the drill is there. So again, there's not going to be sound on this. I apologize for that. This is another football player. It actually happens to also be a quarterback. It's a high school football player. And so you can see, if I can pause it and make this go away. You can see there, that's the head of the femur. And then this is the acetabulum. So it's a posterior dislocation. It's the same mechanism of injury I was just describing to you. And so what they're going to do is they're going to reduce that. So since it's gone posteriorly, what they're going to have to do is actually manually pull it back anteriorly, right? And so what you'll see them do here, there's a few kind of funny things about this. You know, it's an unfortunate injury. So the first funny thing is how big this black box is. You can guess why that's there. But the other thing, so what they're going to do is essentially apply an anterior force to the hip. You got to pull it back into the socket. And so you're going to have to get one of the other, so we've got it in flexion, we're going to pull it back into the socket, and somebody's going to have to come up and stabilize his ASIS, so his pelvis. They're going to press down right here on the ASIS to stabilize the pelvis. You're going to see it pop back in place. Pop. There's that. And so now it's back in place. They're checking leg length there. There's no discrepancy. Both legs are the same length. And then they take a follow-up x-ray. Back in place. That's good. Here's where things get a little rough. So I'm going to fast forward some because they're going to do some draping. So what they're going to do, and this is the gross part. So this is the part you don't have to watch if you're squeaming. But what they're going to do here is they're going to drill what's called a traction pin. So they're going to take that drill, and they're actually going to drill through the medial and lateral epicondyles of the femur. And so, like I said, this is the gross part, so feel free not to watch. But one of the rough parts, so you can see, remember the epicondyles are rounded, and so you can watch them trying to find the flat spot. It's hard to find. So watch the drill slip around a little bit. Like I said, I was always amazed how much orthopedics is like shop class.
So she's just like scraping off bone there when she's trying to find the flat spot.
Yeah, yes he is. You're gonna feel it tomorrow, but yeah. All right, so we're gonna find the flat spots. We're gonna drill. All right, drill all the way through. So again, going through both epicondyles, and then the grossest part here is when it comes out the other side. So eventually they get it through. They have to use a scalpel to get it through the skin. But anyway, so what they do once they got the pin through, so that's the pin all the way through the femur, okay? And so we're going to pack it some, keep moving. Then we're going to make sure this keeps playing. All right, so they got a couple strings that they've attached to those pins. All right, and then on the end of the bed, they got a bag of water. And so they're going to attach this bag of water to those strings that are attached to that pin that runs through his femur. And he'll be like that for, I believe, at least 24 hours, although I haven't had to look at that literature in a while. But I think it's at least 24 hours where he's going to be like this.
Dislocating him.
Good guess. So he's got his medical bag of water there. All right. So we'll leave it there on the medical bag of water. So why did they do that? They dislocated his hip. Okay, they put it back. Why'd they have to go and drill a big pin through his hip and then hang a bag of water off his leg? Ray's are traumatized from the video. So the answer to that question is, so what is inside of the hip joint? Remember, there's a structure inside of the acetabulum that is not inside of the glenohumeral joint. What is the difference inside of the joint? You remember from last time?
Oh, the artery.
There's an artery, right? So there's an artery that runs from the socket that runs from the acetabulum into the head of the femur. Well, you can imagine if you dislocate your hip joint, you just tore that artery. It's pretty small, but you tore that artery. And so what that means then is you cut off some of the blood flow to the head of the femur. Not all of it. You have a separate set of arteries, the circumflex arteries, that run in through the neck of the femur and supply some of the head. But at the very least, you've cut off some of the blood supply to the head of the femur. But what happens when you cut off blood supply to a tissue? It's going to die, right? And so if you cut off blood supply to the head of the femur, some of those, the chondrocytes will die. Also, you've disrupted the synovial fluid, so they're not getting their nutrition anyway. But the underlying osteocytes, the underlying osseous tissue is going to die as well. And so then what ends up happening then is that once we reduce that hip dislocation, you're going to get a spasm of the muscles around the hip. And you've got some really big, strong muscles around the hip. You've got, your glute muscles, you've got one of the quad muscles. And so when those muscles spasm, they're going to pull the head of the femur into the acetabulum. So they're going to really compress that joint. And if you've lost blood supply to the head of the femur, you've got underlying tissue damage there, right? So if you have that really significant compression combined with tissue damage, you're going to flatten the head of the femur. And so what they're doing with this traction pin is they're trying to keep those two surfaces apart. They're trying to keep the head of the femur pulled away from the acetabulum to prevent that spasm from damaging the head of the femur. Because if we just reduced it and then left it, you'd get that spasm, drive the head of the femur into the acetabulum, and then it's going to flatten out the head of the femur. Why is that a problem?
And you can't walk.
Yeah, tough to walk if you got a flat head to your femur, right? It has to be able to slide nicely inside that joint. And so if you got a flat joint surface, it's just not going to work. And so if that happens, because that's actually not a super uncommon comorbidity, it's not the best word, but that's not a super uncommon result of a femoral dislocation. And so if that happens, if the femoral head gets flattened out, they're going to need a hip replacement. And so what they're trying to avoid here is the consequence being a hip replacement for this athlete. Because if you're an 18-year-old football player with a hip replacement, you're not a football player anymore, right? So that would be bad. So they're trying to avoid that so that he can hopefully get a good outcome here. So that's why they're doing that.
If you got a hip replacement at 18, wouldn't you have to get it replaced like 5 more times in your lifetime or something like that?
Most of them now last about 25 years, but that's based on they're typically done in people over the age of 65, and they're just not as active. So if you start putting them in 18-year-olds, like, are they really going to last 25 years? Probably not. So yeah, let's say it lasts 15. Yeah, you're going to need several revisions. And so, the longer we can put that off, the better. The other thing in terms of the medical bag of water weighs 8 pounds per gallon, and so you know exactly how much this bag weighs depending on how much you fill it up. David? Yeah, not that I know of. So one of the things, like, students often have asked, like, why don't you just hang it off his ankle? And the answer to that question is if you're pulling on the foot or if you're pulling on the lower leg, then what you're going to do, let's say you're pulling on the lower leg, you're going to lengthen the ACL, the MCL, the PCL. You're going to lengthen out all those knee ligaments, so now you got knee problems in addition to your hip problem. So that's one of the thoughts there. And the same thing if you hang out the foot, now you're messing up the ankle in addition to the hip. And so the idea there is that, yeah, we've got a bad hip, but at least if we put the traction pin up top, we're going to avoid damaging the knee and everything further down the chain. Now, is there a better way than, like, drilling through the femur? I don't know. Maybe, but I'm not aware of any other way that it's done. Good question. Anything else? All right, good. So, see, we already started off a little bit more exciting than last time. All right. So now, into the tedious stuff. Now into muscles. Oh, skipped ahead one. Went too far. So let me double check and make sure my mic is working. Just real quick. And it is not. Oh, yeah, there it is. Okay, good. All right, never mind. We're good. Excellent. All right, so into the muscles. So again, most of these are on that Lab 6 sheet, or actually all of these are somewhere on there. I changed up the order a little bit. I moved the glutes up, but they're all somewhere on that Lab 6 sheet. So the first muscle, which might be listed by the collective name of iliopsoas, but the first muscle is iliacus. And so iliacus originates in that iliac fossa. Remember we talked about that last time? That is that medial surface, the inside, if you will, of the ilium. It originates from that medial surface, medial to the ASIS, and then going posterior from there. So from that iliac fossa, and then it's going to actually run in front of the ilium, in front of the pubis, and it's going to insert on the lesser trochanter of the femur. And so in terms of actions for that muscle, it is one of the most powerful hip flexors combined with its partner psoas. So it's a really powerful hip flexor, and it's also an external rotator at the acetabulofemoral joint at the hip. So that's iliacus. And then typically, it is partnered with the muscle that it works very closely with because the two bellies actually run together, and they insert at the same spot. So it's typically discussed with its partner psoas. Psoas major, I should say, because there is a minor. Minor is just a low back muscle. But psoas major originates from those transverse processes of T12, so the lowest of the thoracic vertebrae, and then all the way through the lumbar section. So you got 5 lumbar or low back vertebrae, and it originates along each of those low back or lumbar vertebrae. So again, in terms of transverse processes, those are the projections. There's a right transverse process and a left transverse process on each vertebrae. And so it's going to arise from each of those on one side. So your right psoas muscle arises from the right transverse processes on each of those lumbar vertebrae. And again, the belly is going to run in together with iliacus and insert there at the lesser trochanter. So same actions, powerful hip flexor, and then it is also an external rotator at the hip. So one of the things about these two muscles, about iliopsoas, is that, so there's a couple things about them. It's important that psoas originates on the low back because psoas is a muscle that tends to cause problems in the hip and low back. Just like we talked about pec minor and the shoulder tending to cause problems in terms of scapular motion, psoas tends to cause low back problems. Because if psoas is tight, then what that's going to do is pull your low back forward and also compress the lumbar spine, right? And so in kids and adolescents, the most common back injury is actually a stress fracture in the low back. I think at least one person in this class told me they had it. Yeah, spondylolysis is a stress fracture in the low back, pretty common, especially in gymnasts and offensive linemen in football. But one of the factors that can lead to that is really tight hip flexors, specifically really tight iliopsoas. And so, again, that can cause that compression in the lumbar vertebrae, which can then lead to that stress fracture. So if you've ever been told, like, hey, don't do sit-ups because they're bad for your low back, the reason for that is because that strengthens and tightens psoas major, which can then compress and hyperextend the low back. So that's probably why you've been told that. The other thing is that iliopsoas, and there's the picture of the two of them together, iliopsoas is one of the most common causes of snapping hip. And I'll talk about another cause here in a second. But oftentimes people will come in, athletes will be like, hey, my hip keeps popping. And so the question is always like, well, what's causing that? One of the most common causes is iliopsoas getting caught on, there's this little projection right here from the ilium, which I mentioned a minute ago, the iliopectineal eminence. So it's just a little projection from the ilium. And so as you extend and internally rotate the hip, so as you bring your leg back and internally rotate it, that then is going to stretch out this muscle belly, but also move the muscle laterally. And then when they move from a position of extension to flexion, and especially external rotation, then that's going to shorten the muscle back up, and as they externally rotate, it actually causes the muscle to move a little bit medially, and so it tends to kind of click or drag on that iliopectineal eminence. And so if somebody's like, every time I flex my hip, it snaps, or if you're like me, every time I do a sit-up or something like that, like a really a resisted hip flexion motion, you get a snapping in your hip, that's your iliopsoas getting caught on that iliopectineal eminence. It's benign. Unless it hurts you, don't worry about it. It's just annoying. But it does mean that your iliopsoas is probably fairly tight, or maybe you just have an extra large eminence there. But most likely, iliopsoas is fairly tight. So, an important couple muscles there. Yep.
Have you ever heard of the so right, like that stretching? I don't even know like what it actually does, but it's like this little like U-shaped thing, and it's supposed to like they stretch out your psoas. I don't really know how it works.
I have not.
It's like a product.
I have a
picture.
What's that?
I can show you a picture of it.
Oh, sure. Let's see what that thing looks like.
Yeah, it's supposed to like be able to get
Yeah, so the tough part here, of course, is that so you can get at iliacus. So like if you find your ASIS, and then if you're like you have your knees in flexion, and then you kind of grab in there. Oh, okay, all right. I can see that. I don't know how well that would work, but sure. So you can actually like manually, if you go to a manual therapist or massage therapist, whatever. If your hips are up in flexion, you can kind of dig in there at the iliacus, and basically you kind of pin it down and then like have them passively extend their hip. It's an interesting stretch. Feels pretty good. Psoas is hard to get at because of its origin in the low back, because of course your intestines and stuff are here, and so it's tough to really get at psoas. And so that's a little problematic. So in terms of like actual stretches, usually the recommendation is to do kind of like that kneeling stretch, and then internally rotate your hip a little bit, and then stretch forward. That's one of the more effective stretches for it. But it is tough to get at. So you can use a lacrosse ball if you don't want to go in so far as to buy that gimmick. The tough part with a lacrosse ball is you also have your femoral nerve that innervates the front part of your thigh, also sits right there. And so if you've got your lacrosse ball like inside of your pelvis and you roll a little bit too far medially, you'll get like this zinging sensation across the front of your thigh. That's your femoral nerve, so try to stay off of that. So that's one of the tough parts. It's tough to get at, it's tough to stretch. So yeah. One of the less problematic ones, pectineus. So pectineus is another hip flexor. It's also an adductor. So it originates from the pectineal line of the pubis. Remember last time we talked about the superior pubic ramus and inferior pubic ramus? So pectineus originates from that superior pubic ramus. And specifically on that superior pubic ramus, the pectineal line. And it's going to insert just inferior, just below the lesser trochanter, so just below what we see with iliopsoas. So it is an adductor, a flexor, and also the anatomy apps is an internal rotator, and that's the only thing I've ever seen called pectineus an internal rotator. Usually it's referred to as external. but for the sake of consistency, we'll stick with what this anatomy app says, and we'll say it's an internal rotator. But at the very least, it's a pretty minor internal rotator, and again, I can't imagine how it does that, but it is a flexor and an adductor for sure. So flexion, adduction for sure for pectineus. And so pectineus, if we put all the muscles back on there, is highlighted there. So not quite all the muscles. So I've taken off sartorius, which is a long muscle that would run in through here. And then here's iliopsoas. You can see their bellies running together. And then right next to iliopsoas is pectineus. All right. So next one's rectus femoris. I mentioned this last time we talked about muscle origins. So we talked about the AIIS, the anterior inferior iliac spine. That's the site of origin of rectus femoris. And the other thing I mentioned last time, so rectus femoris is one of the 4 quad muscles, the quad muscles being the muscles on the front of your thigh that sort of make that V shape if somebody's fairly lean, right in the middle of the thigh. So that's rectus femoris. It sits in that V, or it is that V. And then it's going to insert with the rest of the quad muscles into the tibia. Specifically on the tibia, it's called the tibial tuberosity. And you're going to see different terminology in different books or different apps that talk about the patellar tendon or the patellar ligament, or in this case, the quadriceps tendon. So what are those, or what's a way to conceptualize those? So just above the knee cap, which is your patella, you have a bundle of connective tissue where all of the quad group comes together. And so oftentimes that's referred to as the quadriceps tendon or the patellar tendon. Because remember, tendons insert muscles into bones, right? And then below your patella, you have another band of connective tissue that runs from the inferior pole of the patella to the tibial tuberosity. Sometimes that's called the patellar tendon because it's an extension of that original connective tissue or that superior connective tissue. But also, just for nomenclature, sometimes that's called the patellar ligament because it actually technically runs from the patella to the tibial tuberosity, and so sometimes it's referred to as the ligament. I will refer to them all collectively as the patellar tendon, just to make life easier. So, patellar tendon below the patella, or inferior to the patella, and then patellar tendon on top of it. And so this, again, the anatomy app calls the quadriceps tendon, same thing. So in terms of what rectus femoris does, at the hip, it is a flexor. So it is an acetabulofemoral flexor, and then at the knee, all 4 of the quad muscles are extensors. So you see tibiofemoral joint, which is the knee joint, so it's an extensor there. So one of the things I like to ask about a lot is that, or I want to make sure you know, all 4 of the quad muscles, so those anterior thigh muscles, all 4 of them are knee extensors, but only one, rectus femoris, acts on the hip. The other 3 originate somewhere on the femur, so they can't do anything at the hip. So rectus femoris is the only one of the 4 that has any action to the hip. And then with the other muscles added in, again, it's going to make that sort of a V shape on the anterior aspect of the femur. So that's it highlighted there. And so I mentioned last time before I get on the sartorius, so just like iliopsoas, particularly if psoas is tight, it can hyperextend and compress the low back. It can also cause an anterior pelvic tilt, which is to take the ASIS and rotate down toward the floor. Rectus femoris is another one of the ones that causes problems with this. So oftentimes people do lots of quad strengthening or lots of hip flexor exercises. So even things like planks, like if you watch people do planks, most people do them really crappy. So if you do planks or bridges, the way they're supposed to be done is you draw in first, you suck your belly button in. That's going to tilt your pelvis posteriorly, and then you hold it. And as soon as you can't maintain that sucked in position where your pelvis tilts anteriorly again, you're supposed to stop. But of course, most people don't do that. They're like, I can do it for like 5 minutes. And what they do is they put their butt up in the air a little bit, and so you're recruiting rectus femoris and also iliopsoas, which is actually not what you're trying to do with that exercise. You're trying to recruit one of the deeper abdominal muscles with that exercise. So if people do a lot of those types of exercises where they're hip strengthening and they're quad strengthening, rectus femoris can be tight, and then that can also cause that anterior tilt of the pelvis, which can then cause low back pain. So we have to look in terms of low back pain, particularly in athletes, at the tightness of the quads and the tightness of the hip flexors. Point of curiosity, how would you tell somebody's rectus femoris is tight? Any guesses? It's actually pretty easy. So basically all you have them do is sit on a table. I'll move my mic thing for a second. Have them sit on a table, okay, like this, their knees off the end. They grab this leg and they fall backwards, and if this other leg that's straight extends whenever they lean back, that's because that rectus femoris is tight. So as you tilt the pelvis backwards, it's lengthening rectus femoris there, which then has to have some give to it, so it's going to extend the knee. Called the top test. So you probably, if you've been to the doctor for back pain, hip pain, quad pain, you've probably done that test at some point in your life. So it's pretty straightforward to see if that muscle's tight. All right, moving on. Sartorius. So sartorius originates at the ASIS, the anterior superior iliac spine, runs down to an area of the tibia called the pes anserine. And where is the pes anserine? It is basically medial to the tibial tuberosity. And the tibial tuberosity, again, that's where the quad muscles insert. It's where the patellar tendon inserts. So the tibial tuberosity is a pretty obvious knob in the middle of your shin, where your quads insert. And so just medial to that is the pes anserine. And so there are three muscles that insert at the pes anserine. They are sartorius, this one, gracilis, which is the last muscle we'll talk about, and then semitendinosus, which is one of the hamstring muscles. So three muscles insert there at the pes anserine. So you're going to see that again. Sartorius is the longest muscle in the body. It does a lot of things, but it's not really strong in any of them. So sartorius at the hip is a flexor, an abductor, and an external rotator. And because sartorius crosses the knee, it's also active there as well. So it's a knee flexor, and then an internal rotator. So it takes the tibial tuberosity and rotates it toward the midline. So it does five things, but it's not strong in any of them. And just as a shorthand, to know four of the five things that sartorius does, if you're seated and you cross one leg over the other, you just did four of sartorius's five actions. So when I cross one leg over, I'm going to have to flex the hip, I'm going to abduct it, externally rotate it, and then I'm going to flex at the knee, and then I cross my leg over. So that's four of your five sartorius actions. Hip flexion, abduction, external rotation, knee flexion, and then a minor action, internal rotation of the shin, or the tibiofemoral joint. And so that's it there with all of its friends. So it is a superficial muscle. To see some of the adductor muscles, to see them better, we have to take it off. So there's sartorius, obviously the orange one. There's iliopsoas again. Here's pectineus again. So those are the muscles we already talked about. All right. One of the more fun names, tensor fascia lata, or TFL. So I'm usually just going to say TFL, say the abbreviation, because the rest of the name's kind of weird. So TFL originates from the ASIS, the more lateral and posterior aspect, but from the ASIS and also from the anterior iliac crest. And it's going to insert into the iliotibial band or the iliotibial tract. It's the same thing. In terms of nomenclature, I'm going to say IT band or iliotibial band. The anatomy app says iliotibial tract. Both are correct. So if you say either one, people are going to know what you're talking about. But I say IT band. So insert into the IT band or IT tract. And the iliotibial band or the iliotibial tract inserts on the lateral aspect of the tibia at an area called Gerdy's tubercle. And so we'll find Gerdy's tubercle tomorrow in the lab, but Gerdy's tubercle is basically, once you find the lateral condyle of the tibia, there's a really obvious flat kind of angled spot there on the lateral aspect of the tibia, just below the plateau, and that's Gerdy's tubercle. So in terms of actions of TFL, so it's a flexor of the hip, an abductor, and an internal rotator. And while I'm thinking about it, so this PDF, when it pops up, there we go, is up in Canvas. And again, for us, the most useful thing is probably the origin insertion stuff. So in terms of the things I was just talking about with the pes anserine and Gerdy's tubercle, so tibial tuberosity here. So you can see three muscles insert there along the medial aspect of the tibia. That's the area of the pes anserine. And then where the iliotibial tract inserts there, that is Gerdy's tubercle. So those are all of those landmarks. And like I said, that's up in Canvas if you want to look at it. It's pretty helpful, little graphic. Yep.
So it technically inserts along the tibia. Why doesn't it have any motion in the knee?
Because when it shortens, I mean, I guess you could argue that it's a little bit of a knee extensor. That's a great question. So yeah, potentially it could be a knee extensor, but as you flex and extend the knee, the IT band actually shifts back and forth. Hopefully you can't feel it. If you do, then that's a problem. but it actually shifts back and forth between extensor and flexor. So if anything, it might be a weak knee extensor, but I don't think I've seen any textbooks categorize it as that. But I guess it'd be interesting to know, like if you sat there and did knee extension, is that involved? If you did an EMG study, is that active? It'd be hard to differentiate though, because of course it's going to be active as a stabilizer of the hip, so it'd be hard to tell that it's working at the knee and not the hip. And there's it with everything else. So that's it inserting into the IT tract or IT band. And that's the IT band itself. So the iliotibial band is a really obvious band of connective tissue that runs from your iliac crest, again, all the way down to Gerdy's tubercle. There's two muscles that insert into the IT band, TFL that we just talked about, and the other one is gluteus maximus. So we'll talk about why that matters here in a second, I think. Forgot how I laid out the slideshow. And there's a lateral view of the IT band. So TFL would be here, and then glute max would be here, and actually into it down here. All right, so here's a case study I have for you. We're going to pretend you're some sort of rehab professional, PT, AT, MD, whatever you want to be. And a 22-year-old woman comes to you complaining of lateral hip pain. What she tells you is that she's been doing some running, she's been trying to run outside, and she's noticed that later into runs, so after a mile or two, her hip starts to get really sore, and she's also noticed that there's kind of a snapping sensation out there. So it feels like it catches and clicks. And she notices that clicking especially happens when she goes up and down stairs, particularly if she takes 2 stairs at a time, so she goes really far into hip flexion to take a step up. Same kind of thing, sometimes getting into or out of really low cars. Let's say somebody she knows has a sports car, and she drops down in there, gets back out, feels a snap in her hip when she gets out of there. And she's also noticed that when she lies on that side at night, so she lays, we're going to pretend it's her right side, when she lays on her right side at night, she gets some dull aching pain in that right hip. So primary complaints, lateral hip pain. When you ask her to point to it, she's going to point to the area of the greater trochanter, which is this pretty big obvious projection out here. So she's got pain right here. Pretty big area though, not like one finger, it's kind of this whole lateral aspect. And then she's got snapping in the hip, where it feels like something just shifts back and forth across there. So what's going on? The answer is her IT band is moving back and forth. So the IT band is moving back and forth. I'll show you postural stuff in a second. So again, there's her picture of her IT band. And actually, let me go back a slide to that. So you can see that the IT band actually runs over the top of the greater trochanter. And if we back it up one picture, so to allow for a nice normal sliding there without pain, you have a bursa under there. Remember, bursa is a little fluid-filled sac, so it's filled with synovial fluid that helps lubricate. So it's going to help the bursa, it's going to help the IT band slide nicely across the greater trochanter without dragging. Well, this particular athlete probably has some weakness of the hip abductor musculature, so gluteus maximus, gluteus medius, gluteus minimus, and as we'll talk about next time, the hip abductor musculature, what it does, so if I abduct the hip in open chain motion, it looks like this. Open chain meaning my foot's not fixed to the floor. So hip abduction, take the leg away from the midline. But in weight bearing, the hip abductors, their job is to keep my pelvis nice and level. Because if my hip abductors are weak, you're going to see the pelvis on the non-weight bearing side, on the swing side, it's going to drop. And so of course when the pelvis drops like that, that's going to pull the iliac crest away from, pull the iliac crest away from the greater trochanter a little bit. And so that's going to pull the IT band tight across the greater trochanter and cause it to click. And so probably her primary issue is that she's got weak hip abductors, and so she's getting some pelvic drop every time she takes a step, pulls the IT band or bowstrings it across the greater trochanter, and it's irritating that bursa. So she has trochanteric bursitis. But there's some other stuff that could be going into that. So we'd also have to look at her normal standing posture. You got normal there on the left. Typically women, more so than men because their pelvis tends to be wider, women are more likely to have that knock-kneed or genu valgum posture there on the far right. And so when that happens, you can imagine if you buckle the knees medially, that's going to pull the IT band really tight across the greater trochanter as well. So if you already have that posture, and then you have relatively weak hip abductors and probably external rotators, that's going to cause the IT band to drag. So there are a number of other things that can cause it too. So sometimes you can get IT band issues with that genu varum, so with that bow-legged. But typically if they're bow-legged, they have IT band problems down here at the knee. It's going to click down here across the lateral epicondyles. Much more common for that. So the other thing, not only do you get IT band friction syndrome or trochanteric bursitis with runners, that's the most common complaint, you also get it with lifting athletes. So athletes will talk about, yeah, when I squat, if I get down to the bottom, I feel a shift in my hip. That's their IT band. And if you're lifting a lot of weight at the bottom, or at the bottom of that movement, that shift is really disconcerting, and so then that can cause them to kind of flinch a little bit, and maybe cause some low back issues, that kind of thing. So we want to get that fixed. Other things, just as an aside, so one of the things that can also lead to this junior valgum posture are foot problems. They have really flat arches that can cause a needle buckle medially, and then it can present as a hip problem, but the underlying problem is actually a foot issue. So then things get complicated. So that's pretty common. You're going to see that in a lot of your athletes. Again, more commonly your female athletes than your males because of that wider pelvis, but both athletes it's not uncommon to get snapping hip in either set of athletes. All right, so we'll do the hamstring group. That'll probably be our last thing for today. Will be the hammies. So the hamstring group, 3 muscles in the hamstring group: semimembranosus, semitendinosus, and biceps femoris. So the first one there is semimembranosus. So you can see it originates there. Well, all 3 hamstring muscles originate at least in part on the ischial tuberosity. Biceps femoris has a short head that originates along the linea aspera, but all 3 of them originate at least in part on the ischial tuberosity. So semimembranosus originates there at the ischial tuberosity, inserts kind of on the posteromedial aspect of the tibia, at the tibial plateau there. All 3 hamstring muscles are extensors at the hip, so they're extensor AF, and then they're also knee flexors, so flexion TF, so tibiofemoral joint, again, is the knee joint. So hip extensors, knee flexors, all 3 do that. And then the 2 medial ones, semimembranosus, semitendinosus, are internal rotators at the knee, not at the hip, but at the knee. And then biceps femoris is a lateral rotator, or external rotator at the knee, or tibiofemoral joint. So one of the things about the hamstrings is that because they're hip extensors, or they are hip extensors, and so we use them for like slower running speeds, lower intensity hip extension, if you will. So like during normal walking, that's primarily your hamstrings involved in hip extension as opposed to glute max. Glute max is your biggest, most powerful hip extensor, but we don't recruit it very often. So your hamstrings are the ones that really drive during normal gait. And also if you're engaged in endurance running, that is primarily hamstring driven activity. Now the faster you run, if you switch from a 7-minute mile pace or something, 8-minute mile pace to sprinting, now you're having to push off harder, you're taking up longer stride lengths, and so with that, now you're going to start to recruit glute max more. So the faster you run, the more you recruit glute max. The slower you run or walk, that tends to be more hamstring driven. Yep. They are both being activated, yep. Yes, the hamstrings are still involved. It's kind of like working your way up from those type 1 to type 2 X fibers. So we're working your way into glute max. Yep, good question. All right, so one of the other things about semimembranosus, it's deep to semitendinosus. And so you can see there on the picture where it's yellow, it's underneath semitendinosus. So semitendinosus is this one here. There's semitendinosus. So again, ischial tuberosity. It's going to insert the pes anserine, again, along the sartorius. So that medial aspect of the tibia, medial to the tibial tuberosity. Same 3 actions as semimembranosus. So hip extension, or acetabulofemoral extension, tibiofemoral flexion, tibiofemoral internal rotation. Semitendinosus is the superficial one, obviously between it and membranosus. Its tendon's really obvious whenever you flex your knee. It's the most cord-like tendon back there. Pretty easy to find. Sometimes it's a tendon that is used for grafting elsewhere. So it has the potentially you could use it for like an ACL graft. That's one of the places where they'll harvest the tendon. Sometimes is from semitendinosus to replace your ACL. And then the last one is biceps femoris. So biceps femoris, again, has 2 origins because biceps has 2 heads. So biceps femoris also originates along the ischial tuberosity. So that's the long head. The short head of biceps femoris, there's the highlighted version of semitendinosus. And then there's biceps femoris by itself, and then there's biceps femoris highlighted. So the long head of biceps femoris originates at the ischial tuberosity. Short head originates along the linea aspera, along the lateral aspect of it. Both those two heads come together and insert into the head of the fibula. The app also says lateral condyle of the fibula, but I'm concerned that you know it inserts at the head of the fibula. So two of the same three actions as the other two. So acetabulofemoral extension, hip extension, tibiofemoral flexion, knee flexion, and then external or lateral rotation at the knee. So those are your three hamstring muscles. So the hamstring muscles then include semimembranosus, semitendinosus, and biceps femoris. And I'm probably always going to say them in that order because that's the order that I memorized them. So that's medial to lateral. So MTB, how I memorized them. Membranosus, tendinosus, biceps fem is their order medial to lateral. So membranosus and tendinosus are both on the medial aspect of the leg, but membranosus is slightly more medial than tendinosus because, again, you can see its little belly here. So it's slightly more medial, so I always go MTB. All right, speaking of hamstrings, let's talk about hamstring strains. This will be our last thing for today. So hamstring strains, as you know, fairly common injuries, especially in your sprint-type athletes. So those can be broken up into two different types with respect to the mechanism of injury. So typically a type 1 hamstring injury is one that we associate with sprinting. And a type 1 injury that we associate with sprinting is almost always, like 80+% of the time, almost always a biceps femoris injury. So when you injure your hamstring sprinting, it's almost always biceps fem. And what ends up happening, the actual mechanism of injury there, I should back up a little bit. So all of the hamstring muscles are biarticular muscles, meaning they cross two joints. And we talked about this a little bit with the biceps brachii in the arm. Any muscle that crosses more than one joint is more likely to be injured than a muscle that only crosses one joint. Because it's how an active two is stabilizing at one and actually moving the other, and so then it tends to be more likely to be injured. All three hamstrings cross two joints, they're more likely to be injured than several other muscles. So like the quad muscles, if you're going to injure the quads, it's almost always rectus fem, which is a bicep, or which is a biarticular muscle. The rest of the quad muscles, rarely injured. So with respect to the hamstrings and the type 1 injury, what ends up happening is as you reach the end of the swing phase where your hip is in flexion and your knee is moving from flexion to extension, biceps femoris is going to be the most active in slowing the knee down into extension. So it's going to contract eccentrically, so it's going to contract the lengthen, and then it has to move from that slowing your leg down to a rapid concentric contraction, so that's to change direction and shorten really quickly when your heel hits the ground, and so when you do that, it's easy to overload it. So I have a video, it doesn't need sound, but it's that classic type 1 injury, which is Lolo Jones doing it. Watch her right leg, she goes over this hurdle, and you can see she grabs that lateral aspect, so it's a biceps femoris injury. But what's happening there on the hurdles is, again, you're having to quickly stop the knee from extending, and then move into hip extension. So as you do that, then you can overload that muscle. That's as opposed to a type 2 injury. And a type 2 injury is typically, it's an overstretch injury. So, sorry the sound doesn't work. Because you actually hear this guy's pop. It's pretty crazy. But anyway, a type 2 injury is an overstretch injury. And so typically what happens, you see type 2 injuries in like dancers where they have extended the knee and they fully flex the hip. And so it can get overloaded or overstretched in that. And so you're going to see it in this karate instructor. We'll fast forward through most of this. But watch his left leg here in a second. So he's demonstrating how to do some kind of a kick, not a karate person. So watch his left leg in the position that his pelvis and hip are in. And so you can see he grabs there. So what ends up happening there, of course, is that it's going to be extended at the knee, or his knee is going to be extended, so his hamstrings are going to be stretched out, and then as he sort of loses balance a little bit and falls forward, the hamstrings are going to have to contract to stabilize the pelvis to keep it from tilting anteriorly, and that just overloads them. And so almost always with this overstretch or type 2 injury, you're going to get an injury to the semimembranosus muscle. So the stretch-related ones tend to be semimembranosus. The sprinting ones tend to be biceps femoris. In terms of grades, 1, 2, 3, it's kind of like we talked about with the ligament sprains, where with a grade 1, you overstretch the fibers, grade 2 is a partial tear, grade 3 is a full tear. They typically take, so grade 1 takes about 2 weeks, grade 2 takes about 3 to 4 weeks, and then grade 3, if you've ruptured the muscle, takes like 3 months. So there's a big difference between a 2 and a 3. With a grade 2, you tend to get quite a bit of bruising. So you can see this is a grade 2, or the aftermath of a grade 2 hamstring strain there, significant bruising on the posterior thigh. And so one of the big exercises that's certainly in vogue now to prevent hamstring strains is called a Nordic, I forget the rest of it, Nordic something or other. I don't know why I had blanking on that. Anyway, yep. Thank you, Nordic hamstring exercise. And so what you're doing here is you can see the starting position is where he's kind of blurred out. And then you're just going to have a partner hold your feet down and then slowly lower yourself to the floor. And so what you're doing then is getting a really powerful eccentric contraction of the hamstrings. And really what Nordic hamstring exercises are good at are preventing those type 1, those sprinting type strains, because it's that eccentric to concentric conversion in biceps femoris that tends to cause the overloading of it. So if you can really focus on that eccentric strengthening of the muscle, that reduces the incidence of hamstring strains pretty significantly. All right, so that's all I got for today. So we'll pick up with the rest of the musculature next time, and then we'll also get into some of the knee anatomy next time as well. So we'll see y'all then.